Hello learners, welcome to module eLearn 16.1 on agents used in dyslipidemia, part 1. Let me introduce to you the star-studded cast of dyslipidemia. There's always a good guy and a bad guy to every movie, right? The good guy in this case is the high-density lipoprotein, or HDL-C. The bad guy is the low-density lipoprotein, or LDL-C. And the ugly sidekick is the triglycerides, or known as TGs. Unfortunately, the star of the show this time is going to be the LDL-C, and we'll be exploring more about treating LDL-C in the subsequent slides. This slide tabulates agents commonly used in dyslipidemia and particularly tailored to Singapore setting. When we talk about treating LDL, I would like you to think about statins, ezetimibe, as well as PCSK9 inhibitors, and we'll be going through them in detail in the subsequent slides. This is the range of LDL lowering that they each confer. And essentially, I just want to bring up that even though the fibrate class, fenofibrate, is not used for LDL lowering primarily, it's used more for triglyceride lowering, it's also got some LDL effects. Additionally, PCSK9 inhibitors, evolocumab and elarutamab, have got an impact of Lp(a), which is a subfraction of the lipoprotein that's non-HDL. When we talk about fibrates, we are thinking about them reducing triglyceride levels. Similarly with omega-3 fatty acids, however, there's only one omega-3 fatty acid that's labeled in Singapore for use for that purpose. The OTCs are not commonly used for that purpose because of the fact that they are not studied in that particular way. Now, the last group of agents that we want to mention is really niacin, and niacin is not available in Singapore anymore, unfortunately. It's actually quite a useful drug. If you look at how its profile is, it even increases the good cholesterol, which is HDL. Lastly, I want to mention that cholestyramine can increase triglyceride levels for any patients. So please be very careful when cholestyramine is being used in a patient to reduce LDL. That's its primary indication. It can cause a very high triglyceride level as a result. I remember years ago when I saw a patient in the clinic, he developed transaminitis or raised liver enzymes due to a statin. And the medical officer well-meaningly switched this patient to cholestyramine then. And this patient also had high triglycerides at baseline levels. By the time he came to see me in the big clinic, his triglycerides was so high, it was 20 plus. I nearly fell off my chair. So that was a really frightening moment there. And I'll never forget that one of the adverse drug reactions to cholestyramine is a raised hypertriglyceridemia. Let's focus on the main star LDL-C. On the right-hand side is the cholesterol cycle, which has already been covered. In the normal circumstances, the LDL is important to carry the cholesterol that's made by the liver to the rest of the tissues so that important things like the hormones can be made for the critical functioning of our body. However, when cholesterol is in excess, what happens is the LDL will carry it and deposit it into, say, the vascular walls, and this is going to cause problems with atherogenesis. So one of the ways to reduce this problem is to inhibit the HMG-CoA reductase enzyme, and this is commonly done by the use of statins. By inhibiting the HMG-CoA reductase, we reduce the cholesterol that's available in the body, causing an LDL receptor upregulation on the liver, and that causes the liver to take up more LDL to be destroyed and therefore reducing the level of LDL in the body. The other pathway to reduce cholesterol absorption is to block the protein, which is the Niemann-Pick C1-like protein. The drug that's commonly used is called ezetimibe. The good news with ezetimibe is while it blocks cholesterol absorption, it does not affect absorption of fat-soluble nutrients. And that's good news because the fat-soluble nutrients is important for the normal functioning of our body. Now, ezetimibe is not used as monotherapy commonly. It's used as an add-on to statins when LDL is not yet at goal. It's usually used as a monotherapy on its own only when people have been proven to not be able to tolerate multiple statins, meaning we will have cycled through the statins to prove that they cannot take statins before ezetimibe is used as monotherapy. This is because the statins have been very convincingly proven to reduce mortality, and they've also had data to reduce the atherosclerotic plaques even in blood vessels. Therefore, ezetimibe is usually used as an adjunct or monotherapy only when people cannot tolerate the statins. Here's a slide on a comparison of statin potencies that all must take note of. The direction of the arrow shows increasing potency. Fulvastatin, pravastatin, and lovastatin are equipotent. Simva twice as potent as lova, atorva twice as potent as Simva, and Rosuva twice as potent as atorva. The tables in the middle and the right-hand side are showing similar items. However, in the green and white table, I have listed out for you the addition of ezetimibe as well, and the propensity of the various drugs and their combinations in reducing percentage of LDL as well as triglycerides. In literature, you would see a lot of allusion these days to moderate intensity and high intensity statins. What this means is the ability of statins to reduce LDL by 30 to 49% where moderate intensity is concerned. And when we refer to high intensity, we're talking about statins' ability to reduce LDL by more than 50%. The doses are seen in the boxes over here, and as you observe that only atorvastatin and rosuvastatin are capable of reducing LDL by more than 50%, and these are what we call high-intensity statins. Correspondingly, in the left-hand side, in the green and blue boxes, you would see the combination of ezetimibe and statins. If you recall, ezetimibe on its own can reduce LDL up to 20% by itself. When it's used with a statin, it can add on additional LDL lowering impact. Now, if you eat a lot of cholesterol in your diet, ezetimibe is likely to be effective. However, if you don't eat a lot of cholesterol in your diet, I don't think ezetimibe is going to be as effective as statins would be. Another caveat that one should note is the doubling of dose of a statin confers an additional 6 to 7% reduction of LDL lowering effect. Note that the percentages are a rough guide and can differ from reference to reference. Remember that patients do not read textbooks, and it's critically important for us to look at the response of a person before we decide on how we're going to adjust therapy. These percentages are useful when we are thinking about reducing the level of LDL for people who are not at high risk of ASCVD. People who are high risk of ASCVD, for example, someone with acute coronary syndrome or a myocardial infarction, or even a new stroke. That is when high-intensity statins are commonly used, and you would see that are commonly prescribed. Statins are an important class of medications that are first line in reducing LDL used in Singapore. Commonly used statins in Singapore include atorvastatin and rosuvastatin, less so simvastatin, and even less so lovastatin and pravastatin because of the lack of potency compared to atorvastatin and rosuvastatin. Now, atorva and rosuva have become generic, and therefore, because of the increased potency and the convenience of a longer half-life, they are much more used now these days compared to the other statins. On the right-hand side is a screenshot taken out of MediView. I would encourage all of you as you go out to your PCT to have a look at the preparations available in Singapore. Now, the clinical effects of statins are diverse in absorption, bioavailability, plasma protein binding, excretion, and lipophilicity, and that explains for the differential effects of statins, particularly in muscle side effects. Significant first pass is achieved through the CYP450 isoenzymes, which you will learn more under liver, except pravastatin, rosuvastatin, and pitavastatin, which is thankfully not available in Singapore. For the drug-drug interactions, we will be exploring more on the CYP enzymes, and that will be on subsequent slides. Statins are commonly prescribed as ON, or at night, but atorvastatin and rosuvastatin have long half-lives, and therefore may be taken as OM. LDL lowering effects are similar whether you give it OM or ON. Prescribing as ON is still preferred these days because of the purported pleiotropic effects. And unless adherence issues require some sort of OM dosing with the other medications, the default is still to give statins at night. You do need to be cautious for patients who are pregnant or breastfeeding because it's contraindicated. It's also contraindicated in active liver disease, persistent elevations of transaminases or liver enzymes. And common side effects include muscular side effects. This should be a lot more important with people with drug-drug interactions or DDI. And I want to tell you the effect of nocebo effect. So there was a study that compared people who were on statins and given placebos. They were all told that they were given statins. Now, the interesting thing is that people who are on placebo had the same incidence of muscular complaints compared to those on statins, thereby proving that a lot of these muscle side effects are known as nocebo. All that being said, if someone complains of a muscular side effect, it's always important to address that and not just wave them off to just a nocebo effect. It is important to spend time explaining and reassuring the patients as well. And this is what we learned with shared decision making. There's also the other common ADR, which is liver enzyme derangements, or LFTs. All these will be dealt with in more detail in the subsequent slides. Here's a slide on statin-associated side effects. The big star goes with the statin-associated muscle symptoms, or SAMS, because this is a very, very common issue that bother a lot of patients, and we'll be going through this in a lot more detail in subsequent slides. The other side effects include new onset diabetes mellitus, which I don't really think is caused by the statins because it doesn't quite explain with respect of the mechanism of action that statins could possibly be causing new onset diabetes mellitus. But I think that is associated with metabolic syndrome, a syndrome where people are very fat and also have high blood pressure and usually insulin resistance type of a syndrome. And therefore, the people that we use statins in for this group of people tend to have more diabetes because they're already at risk. And I believe that that is the association with new onset diabetes and not so much that the statins themselves cause diabetes mellitus. The other commonly associated side effects are liver, as well as central nervous system side effects. And you will sometimes hear people say that their memories are affected because they're on statins. Now, these two are a little bit more rare, and we will be exploring the liver side effects in subsequent slides as well. Here's a chart on risk factors for SAMS. Now, someone who is more than 75, female, low BMI, and Asian, and sometimes genetic factors are particularly important. You don't have to memorize all of this, but just roughly know some of these risk factors at the back of your mind when you're looking at a patient. Clearly, the more risk factors you have that's concomitant, the more your risk. For example, if someone has got concomitant renal impairment and also a drug that interacts, or they could be taking grapefruit juice or cranberry juice, which inhibit 3A4, that's where the statins mostly are being metabolized, with the exception of rosuvastatin, they could be at increased risk of SAMS. People who drink excess alcohol and also drug abuse can also be at risk of SAMS. Let's talk about some lab tests you may encounter in the context of lipid therapies. The first is creatine kinase, and a snip of the lab reference form has been put there for ease of reference. Now, the CK is an indicator of muscle injury and is very, very sensitive. So for people who take excessive alcohols, had a seizure, or has undergone rigorous activities like dragon boating, or thigh massage, or some drugs like cocaine, corticosteroids, colchicine, and some antiretrovirals used in HIV can cause the CK to rise. Now, these drug-induced myopathies can either be direct or immune-related, and the interesting thing is statins are associated with both of these mechanisms. There are two other terms that you might come in contact with, and one of them is myoglobinuria, and the other is rhabdomyolysis. Now, myoglobinuria is a situation where the protein or myoglobin is concomitantly released in a setting of muscle injury. Now, this protein is actually got heme as incorporated in it, and therefore when this protein gets peed out into your urine can appear red to brown coloration, and this is an indicator that potentially there's muscle breakdown and there might be danger that's impending. This particular myoglobinuria can cause acute kidney injury because the particular protein can cause damage in the renal tubules. With the rhabdomyolysis situation, this is a life-threatening syndrome, and this is usually associated with extreme enzyme elevations of the CK. You would see the myoglobin in the blood also very high. Most times you will also have the red to brown coloration of the urine. Now, electrolyte imbalances and acute kidney injury can also occur. Therefore, one of the counseling points for patients to watch out for would be to look for red to brown coloration of the urine, and also severe muscle pain and really feeling very unwell. And that's the state of rhabdomyolysis, which require immediate medical attention. The other labs that you will see commonly are the liver enzymes in the context of lipid therapies. So for lipid therapies, pay particular attention to the ALT and AST liver enzymes. And sometimes you would see in literature or the going forward slides, you would see ULN, which actually stands for upper limit normal. What this means is it refers to the upper limit normal of your lab results. In this case, for ALT, for example, is 70 units per liter. When you see 3 times upper limit normal, it means that it's more than 210. Now, you don't have to use it like very precisely, but this is just to give you a guide of how high is considered dangerous. And so we'll be alluding to ULN from these slides forward. There'll be more in your liver module next semester about the other liver enzymes, and therefore I shall not give you too many spoilers at this time. This is a busy slide, and before you start to panic, don't worry, you don't need to memorize everything. Let's get through the definitions first on the left-hand side. First, let's start off with those people with muscle symptoms present. With muscle symptoms present and CK being normal, you consider them myalgia. Those with CK levels raised and less than 10 times upper limit normal may be commonly due to exercise or physical activity, or sometimes could be due to statins inducing it. CKs being raised to more than 10 times upper limit normal, you call them myositis. Remember that anything associated with statins and myopathies associated with statins generally would involve the proximal muscles, generally the thigh muscles. And this usually leads to weaknesses in standing up or even tenderness. I remember a recent complaint of a patient who was just 40 plus years old following an MI. And he was telling me a story about how he had difficulty getting out of bed in the morning suddenly one day after about a week of taking the statins following the MI, and he was on high-dose atorvastatin. So in order to allay his fears, we brought forward his appointment and got him to come in for a CK test, which turned out to be normal. And by then, he'd actually overcome that particular problem, and therefore we were all happy. Those with muscle enzyme raised at more than 40 times upper limit normal with accompanying renal impairment and myoglobinuria that we talked about earlier, those are rhabdomyolysis. Remember that rhabdomyolysis is actually a life-threatening situation. Now, for those who have no muscle symptoms but the CK that's raised, you might want to think about checking the thyroid function, or it could be exercise related. If there's no muscular symptoms with a CK that's raised, you don't really need to worry too much about it unless it's super raised, which could be associated with rhabdomyolysis as well, not necessarily due to just statins alone. Now, looking at the chart on the right-hand side, you usually make a decision based on whether there were symptoms or no symptoms of muscle pain or weakness on the statin. Now, if someone has a complaint, that's when you need to be a bit more concerned, and perhaps the dealing with the patient is going to be a bit more urgent. Now, looking at the various pathways, the orange, the yellow, as well as the pink, there are different ways of managing different situations here. Now, I don't need you guys to memorize which level to do what and what to do, because usually protocols will exist in the practice site. Just remember that anytime that anyone has got a CK that's raised, that's above upper limit normal, and they have complaints, especially if there's more than 10 times upper limit normal, you need to be really, really careful to look out for any sort of problems. So here is how you would follow up if you stop the statin, and then when you should reassess again. On the other hand, if someone presents with rhabdomyolysis, that's a situation where you have no time to wait. For those, you right away need to send them to A&E. Let's go to the group without symptoms. Now, when there's no symptoms, as long as the CK is less than 5 times upper limit normal, you don't have to do anything. If the CK is above 5 times upper limit normal, or even up to 10 times upper limit normal, the recommendation is to stop the statin. And the following actions are what you need to do to repeat the CK, and then when do you need to refer to a specialist, or when you need to monitor the enzymes again. I'd just like to reiterate here. Now, this is a situation where we try to cycle statins around until someone can tolerate a statin, because that's how valuable a statin is. Essentially, we have proven that someone still gets a recurrent CK rise due to statins, particularly if they had rhabdomyolysis. We won't want to try and tikam and trial and error again. But if it's a mild CK rise, we could then cycle statins around to see how they respond to the new statin. It's only when you've proven the person can't take a statin that you consider non-statin drugs, for example, ezetimibe that we've talked about earlier, or replacement agents in order to achieve lipid targets. It is also important to continue to emphasize dietary and health behaviors so as to diminish the need for pharmacotherapy. Here we explore the principles of the management of goal-inhibiting statin intolerance. We need to be asking the first question whether there's a compelling indication for the statin therapy for us to press on with it. For example, someone who's post-MI or post-stroke. We also need to be thinking about whether the patient has got the features that limit or preclude the use of statins, for example, active liver disease. And in that setting, the risks may be not worth the benefits anymore to push the statin therapy. Now, we need to also explore if the patient has been fully aware of the indication of the statin treatment, the intended benefits, as well as the safety of statins, and we want to properly counsel them to avoid the nocebo effects. Remember, you can tell patients all they want. If they secretly go home and not take the medications, then it's going to be challenging because they will hide that information from you. Also, consider whether there's been dietary, weight, and exercise goals been executed. Because if they can observe those lifestyle-related management, then it could mean they could save on the dosing of statins, meaning giving them a lower dose of statin, and therefore hopefully reducing the risk of myalgia while taking the statins as well. Also, they may be using supplements that can increase the risk of myalgia. You might have heard of hypocol or red yeast rice, which contains very little bit of statins in them. It's just that these statins are so low that it's not considered a prescription drug. So these use of supplements together can potentially cause myalgia when used together with statins as well. And we need to think about whether there's a challenge and de-challenge or re-challenge occurred to prove to yourself that it really is because of a statin that they got the muscle side effect. And also, if we cycle around the statin. I remember several years ago when I was running the lipid clinic, I had this gentleman who was just muscle aches, on 3 to 4 statins, and it was only on the 4th try that we managed to get him on a low dose lavastatin. The good thing is that he was not one of those high risk patients, and therefore we could settle on a low potency statin like lavastatin. If we wanted to challenge or de-challenge or re-challenge, we have to also involve the patient in decision making, because they might think that you're trying to be funny when you try to give them so many trial and error. They might think that you're trying to make them a guinea pig, and then they'll be very upset with you. Lastly, think about whether there are any non-statin agents that are likely to help to achieve the therapeutic goal. Because if there were, then we can potentially lower the dose of statin or even avoid the statin altogether by giving them the alternative. On the other side of the house is the management of raised LFTs. And with LFTs, we're talking about transaminases, which are ALT and AST that I referred to earlier in the earlier slide. At baseline, we will have done one round of the LFTs to be tested, and as long as it's less than 3 times upper limit normal, we can start the statin. According to the EAS guideline, we will repeat the transaminases in 8 to 12 weeks. As long as the transaminases are less than 3 times upper limit normal, we can continue the statin unless patients have got symptoms of some sort of a hepatitis like fatigue, malaise, or nausea. Now, if the transaminases are more than 3 times upper limit normal, that's when you start to worry. Essentially, if someone is symptomatic, you need to stop the statin right away, and that's quite an understanding that you don't really need to even explain why. We need to then investigate for intrinsic liver disease, and that's when you consider referral to a hepatologist. Someone who has transaminase that's raised more than 3 times upper limit normal but is asymptomatic, that's also when you can consider stopping the statin. You may want to consider other causes, like we've discussed earlier, whether it could be the use of alcohol. Maybe in Singapore, not so relevant, but in the Caucasian countries, maybe drug abuse like cocaine. And then think about reassessing in 6 to 12 weeks, because in order for the transaminase to rise 3 times upper limit normal is really not very safe. And therefore, we want to hold off the statin therapy temporarily and reassess that in about 6 to 12 weeks time. And the various boxes at the bottom shows you the reaction that you need following on. There's really no need to memorize this. Just it's important to know that essentially whenever you have got a patient whose transaminitis occurs, you probably need to be thinking about investigating for underlying causes, because for nothing, usually the LFTs will not rise this way. Okay, so a very common reason why we see LFTs rise in patients whom we start statins is when they have a fatty liver or steatosis. This occurs in very fat patients, or sometimes patients who take very rich foods. It's almost like what we call the pate, where you force feed geese, right, in order to get a fatty liver, so that the delicacy of the pate can be marketed for use for people to use as fine dining. So why does fatty liver why is it associated with rise in liver enzymes? It's mainly because of the fat that's in the liver. And when you treat this when we treat with statin, it causes mobilization of the fat, and therefore somehow the liver enzymes will also accompany with it also rise. So there's really no real need to panic. It's important to maybe question the underlying cause in case there are other hidden issues why this person has got transaminitis. From time immemorial until now, statins use have never been associated with fulminant hepatitis or the risk of killing people due to hepatitis. And commonly, whenever there's transaminitis, it's usually due to a concomitant factor as well. So there's no need to panic whenever you see LFTs rise. Think about it squarely and calmly. Let's shift gears to talk about patient counseling. So remember I talked to you guys about the up-to-date, and if you go into up-to-date and search for statin, for example, you can see on the box on the right-hand side, there's a patient tab. Now, if you click on the patient tab and one of the drugs, for example, atorvastatin, you can see the patient's counseling points on side effects that they need to call the doctors about. And this lists out for you some of the important side effects that you may want to cover with the patient. Now, not every single side effect listed here makes sense, so it's important to also contextualize to the patients when you're talking with them. So what are the ADRs that are commonly associated with statins? And this is all listed out over here. This is basically something that I highlighted in red, which I've added from the original text. So if you look at this whole text over here, if you pause this to have a look at this text over here, if you are a layperson and you listen to all this, you'll be also very worried. So generally, what I suggest that you do when you first encounter the patient, and particularly if you're taking it for the first time, it's important to precede this with telling them, as this is the first time you're taking the medicine, I'll be taking you through some precautions. They may make the medicine sound dangerous and scary, but I would like to assure you that many of our patients are on this medication or this class of medication without significant problems. So it is important for you to pick up any warning signs early in this. So I'm telling you all this list of do's and don'ts, because if you seek medical help early, then any issues that you suffer could be also addressed early. If you have any concerns at all, please call your prescriber before stopping your medications. Okay, so that can be a standard script that you tell patients, particularly if they're taking medicines for the first time. And this will avoid a situation like what I told you guys the other day, like my friend's mother who received a download of A to Z adverse effects from the pharmacy and then go home and told her, I don't take my statin anymore because it sounds so dangerous. All right, so this is an important point for us all to remember, to couch the information carefully and make sure to watch your patient. If they look anxious or they are full of questions on their face, their facial expressions, then it is important for us to slow down and solicit for what they're concerned about. I'm sharing with you an article here from the European Society of Cardiology about this man, this 59-year-old electrician who suffered a heart attack, and all because he didn't take a statin. Why? Because he saw on television documentaries and articles and people who told him that the pills were useless or even harmful. Now, don't be surprised. In Singapore, there are a lot of people who suffer from such misinformation. On the internet, there's so much flame information, bad press about the statins. So that's why I feel so strongly about pharmacists being the superheroes, basically giving the right facts to our patients. And that's why we're also teaching you those skills about shared decision making, how we can elicit concerns from our patients, what they were really worried about, and providing them the right information, telling them how the benefit of a drug could be in preventing cardiovascular outcomes per se, for example. So go pharmacy students who will be future pharmacists, you are just going to save the world. Let's talk about ezetimibe, who is a partner to statins. Now, the screenshot on the right-hand side shows you the various preparations available in Singapore. And I want to call to attention that there are combination drugs by the name of Vytorin, which combines ezetimibe with simvastatin, and that's the only proprietary combination that's available in Singapore. The other statins do not have such a combination available locally. And I also want to highlight that ezetimibe is available in various generic versions, as you can see in the screenshot over there. So please go ahead and play with the MediView access to see the different types of preparations available in Singapore. So ezetimibe basically acts by inhibiting the absorption of cholesterol at the brush border of your small intestine via the steroid transporter, which is the Niemann pig C1 type protein, as we discussed earlier. So by reducing the cholesterol absorbed, it will cause a depletion of the cholesterol store in the liver, and therefore increase the LDL uptake and excretion by the liver as well. The clinical effects, as mentioned earlier, is used as an add-on to the statin therapy and usually not used as a monotherapy, and only when there's proven statin intolerance that we would think about the use of ezetimibe as monotherapy. So because it works as an exogenous LDL absorption inhibitor, the dual inhibition with the exogenous pathway and the endogenous pathway with the statins is achieved when used together with a statin, and therefore there's still an additional effect of LDL lowering when used with a statin. Remember that we talked about how the cholesterol intake, if it's going to be poor with your diet, it might not be all that effective because to start with, you don't eat that much cholesterol anyway in the foods. The ADR are relatively harmless and they are listed over there: upper respiratory tract infection, sinusitis, arthralgia, limb pain, and diarrhea. With this chart, I'm just bringing up the point about how ezetimibe acts together very well with statins. As a monotherapy, it can reduce LDL only up to maybe about 22%. However, when you add it onto statin, there seems to almost be a synergistic effect where the LDL lowering is up to even 27%. So this is quite remarkable, and it's critically important for students to understand that that is why we use therapies together, and therefore the formulation by the MSD company produced Vytorin as a combination.